introduce our first speaker of the day. This is Dr. Ted Hutman. We're delighted to have Dr. Hutman here to speak with you. He did his Ph.D. here at UCLA and worked with Marion Sigmund for years working on her infant projects. Marion Sigmund, as you probably know, has retired, and Ted has been gracious enough to take over her responsibilities, take over the project that she had started on our ACE Center, and continue this very important work in examining early markers of autism in infant siblings of children with autism. And he's going to talk about that research today, so please join me in welcoming Dr. Hutman.
Thank you, Dr. Buchheimer. Thank you all for coming today, bright and early. And while I'm thanking you, I'm going to start my talk today thanking all of the people who contributed to the research that I'm going to talk about. This often gets short shrift. Starting with the faculty collaborators, a lot of graduate students, and I really want to single out the staff research assistants, past and present, who collect the data, interact with the families, interact with the babies, score the data, code the data, and manage an enormous data set. Some of them are here, and they're amazing. I want to thank all of the families who participated in the study, and it's not on the slide, but I want to acknowledge Joni Zuckerbrow-Miller, who helped us. She's in our recruitment office, and she helped us achieve our recruitment goals for this study. And I want to acknowledge the funders at the National Institutes of Health, and also the outstanding staff of the Autism Evaluation Clinic at UCLA. The older siblings with autism are evaluated there and extensively phenotyped, we say. They do a lot of assessments, and they're a tremendous support to our research efforts. So, just since I'm the first speaker of the day, I'll begin with some brief definitions. The diagnostic criteria of the autism spectrum disorders. I do want to emphasize, in addition to what it says here, that the deficits in communication and social reciprocity are significant, severe deficits. So this isn't a matter of a slight atypicality, but these have to cause trouble with functioning in school, in friendships, things like that. And also the presence of, again, debilitating, severe restricted and repetitive behaviors that interfere with life functions. The prevalence of autism, something you hear quite a bit about, is now estimated at 1 in 110 in the United States. So just less than 1% of the population has a diagnosis of ASD. Boys are affected with autism 4 to 5 times more than girls. And this is a note, when I refer to autism spectrum disorders, I'm including autistic disorder, which is the severe presentation, and also Asperger's syndrome for now, and pervasive developmental disorder not otherwise specified. So these are, Dr. Geschwin refers to these as the autisms, but this is what we mean when we talk about the autism spectrum disorders. Something that's quite relevant to the work that we're doing with infants is the typical age of diagnosis. So this is, and I'm sorry if my slides don't precisely match your handouts. It's inevitable with me, and I'm sorry. So it's a personal problem. It's not you, it's me. So 2 different studies got fairly similar results here. So this is a nationwide study looking at prevalence rates in 14 of the United States, and they found median age of diagnosis between 4.5 and 5.5 years. What's nice about this study that's only Pennsylvania is they broke it down by diagnosis. It's not so surprising that the most severe form of the autisms is recognizable, detected, and diagnosed earliest. It's striking how late some of the disorders are being recognized. And the main point that I want to make here in the connection with our work is that it's at least challenging to study a clinical population before they're identified. And that's what we're trying to do. We don't have any reason to believe that this is when autism starts. So I'll talk a little bit more about why we want to understand what's happening in children who are subsequently diagnosed with autism prior to the age at which diagnosis is happening. The reason to study infants is, I think the main reason is because early detection, early identification allows us to start treatment earlier. Early access to treatment corresponds with the best results of treatment, it seems. Also, there's rapid brain development happening in the infant and toddler stages of development. The brain is growing rapidly, and what we want to do is help kids to catch that wave, to optimize the benefits, the learning benefits of early treatment so that they can learn, so that they can keep up or minimize the extent to which they fall behind. The second bullet point here is slightly more of a scientific aim, that what we'd like to be able to do is to identify the cognitive processes that are affected earliest in life in children who are later diagnosed with autism. Identifying those processes will help us to pinpoint where autism is happening in the brain, where brain function is atypical or abnormal. And doing that, if we can identify brain regions, we might even be able to trace that information back to the genes that are associated with the normal or the abnormal development of those brain regions. So this is why we are eager to be able to characterize the early, the emergence, the early characteristics of autism spectrum disorders. And finally, parents of children with autism know that when they have additional children, those babies are at risk for developing autism. And one of the things that we would like to be able to do is provide good diagnostic feedback, or at least developmental feedback on the child's progress, developmental progress in the infant and toddler stages. So I kind of backed into our research design, but this is who we're studying, is the infant siblings of children with autism. They are the best known risk group. We're recruiting them, enrolling them between birth and 6 months of age, long before there are any overt symptoms of autism, and we're following them until age 3, which at this point is the age at which we're comfortable making a clinical diagnosis. So I'll discuss this a little bit more as I go along, but we group them diagnostically at outcome, and then we can go back and we can evaluate the data that we've been collecting, essentially from birth all the way until age 3. So I'll talk a little bit more about the research design and the selection of this group, this high-risk group. Twin studies tell us that autism co-occurs in identical twin pairs much more frequently than in fraternal twin pairs, and that's how we evaluate, that's how we come up with a ratio of, it's a heritability rating. And what we know from those studies is that autism is among the most heritable of all neuropsychiatric conditions. What I've put on this slide is that the epidemiological studies indicate what's happening in the real world, how frequently autism is recurring within families. So this study was headed by a UCLA faculty member in the 80s, and they went out and they just asked people, do you have a child with autism? And they looked at later born children in the same family, and they reported an 8.6% recurrence rate within families. This study is much more recent, and it was done very differently. This is a volunteer sample who reported on family statistics in an online survey. And here what they found is a slightly higher recurrence rate. Their methods were quite different, but they found that autism recurred in 10.9% of families, but in 14.2% of siblings. So the difference is getting at multiple occurrences within families. The infant sibling research design lends itself very nicely to further evaluation of recurrence rates within families, because we control for family structure. In every single participating family, we have We enroll a child before the age at which symptoms are evident and follow them to diagnosis. And so all of the family structures are, the structures of all of the participating families have this in common. We have also collaborated with 11 other universities. So this is a study that UCLA contributed to significantly, let's say. And across these 12 sites, we picked out a sample of 664 infant siblings who met the following criteria. They had to enroll in the study prior to 18 months of age, which may sound sort of old to many of you here. The fact is the mean age of enrollment was 8 months. So we really can't identify autism yet at 8 months of age. We hope to be able to do that soon. And all of these children had to be followed through 36 months. So diagnoses were conferred at or after 36 months of age. And what we found was that 132 of these infant siblings met diagnostic criteria for an autism spectrum disorder at 36 months. Breaking it down, it was about 41% had the severe form of autistic disorder and 59% had PDD-NOS. Our parameter estimate, the mean across these sites was at 18.7%. We reported an 18.7% recurrence rate within families, which was significantly higher than what we anticipated, so that made news. We looked at factors that were associated with recurrence within families. We looked at, we found that boys were 3 times more likely to be diagnosed. So baby boys received the diagnosis 3 times more than baby girls. Babies that were born into families where more than one older sibling had autism, we call these multiplex families, were at significantly elevated risk. So while it looks like boys from multiplex families were at highest risk, there was not a family status by gender interaction in this study. Now, I find this slide perhaps more interesting than the last slide. These are factors that were not associated with risk. I didn't even mention this before, but the Utah study found that babies were more likely to get an autism diagnosis if the older sibling was a girl. We did not support that. There were no characteristics of the older siblings in this study that corresponded with elevated risk. So this is interesting. What it implies is that it doesn't, well, of course it matters, but in terms of this analysis, that it doesn't make a difference if the older child has autistic disorder or PDD, NOS, or Asperger's syndrome. If they were on the spectrum, symptom severity wasn't related, IQ and gender weren't related. Race, ethnicity, and parent characteristics, fortunately, weren't related to outcome. You may be familiar with a study that indicated that paternal age was associated with risk. We found almost the opposite, a trend toward younger fathers having a marginally elevated risk, or babies of younger fathers had a marginally elevated risk. What we're doing with this study that I've reported is we're just doing a binary split of the high-risk infants. At age 36 months, we're just saying yes, no, are they on the spectrum or off the spectrum? So this, to me, and then what we're saying also beyond that, is that about 18.7% of the infant siblings are on the spectrum in this study. And it's nice because we have 12 different sites in the US and Canada. And for studies of this kind, this is a very large sample. For a next step, what we want to do is we want to add a little bit more complexity to this model. We don't want to just say, are they on spectrum or off spectrum? But one of the things that we would like to address is what's happening in this high-risk non-ASD. Are they fine? Or are there other things going on? And so in a follow-up study, the same group, it's actually the same data set. What we've done is we've excluded the kids who received a diagnosis. So we have 507 kids who all have an older sibling with an autism spectrum disorder, but the babies were not diagnosed with autism at 36 months. Now we're adding to the group 324 low-risk infants. So these are children who have no family history of an autism spectrum disorder or other neurodevelopmental disabilities. We are putting into a computer information about ADOS severity score, so autism symptoms, and developmental quotients, both verbal and nonverbal developmental quotients. And we're not, did I add this? We're not telling the computer how many groups to make, but we're running essentially a cluster analysis and finding out what the distributions or patterns within these measures are. And this may be confusing, but what I have here is on the left bar, what is the high bar here is developmental quotient, and that scale is on the left side. The blue bar is symptom severity, so that's transformation of ADOS scores, essentially. And the computer split this whole sample, so we've combined the high risk and the low risk together, and the computer has split them into these 5 clusters. And then what we did is we ran a chi-squared analysis to see if the 2 groups, the high risk and low risk groups, were evenly distributed across these clusters. And lo and behold, they were not. The chi-square was significant. And what we found was that the high risk kids were 5 times, let me just double check that number. Nope. 4 times more likely than the low-risk kids to end up in the cluster at the far right. They were almost 3 times, 2.8 times more likely to end up in this one. So the cluster at the far right that they were perhaps most likely to end up in has average to low developmental quotient and high but subclinical autism symptoms. The group next to it has very low developmental quotient, that's the lowest of all the clusters, but also low autism symptoms. Now, interestingly, the high-risk group was half as likely as the low-risk group to end up in this cluster. So there's not an equal distribution. And what this tells us is that high-risk kids who don't go on to develop autism aren't always typically developing. What this does to our model here is it allows us to say that this is still the 18.7% of high-risk kids who go on to get an autism diagnosis. About 12.3% in our sample, anyway, have other developmental concerns. And again, the characteristics of those other concerns are elevated but subclinical autism-like symptoms. And it could be any of them, but it tends to be social problems. Problems with social reciprocity, that category of the autism diagnosis. And also, sometimes separately in other kids, it's lower IQ. So a developmental quotient, for those of you who don't know, is just an age-related IQ construct. So now what we're able to say is that the kids in this, on my screen, pink area, but I can't tell what you're seeing, we're ready to say that these kids are typically developing. But then it's still going to be interesting, and I'll talk about this a little bit more, we're still going to compare the high-risk typically developing group to a low-risk typically developing group. So what we've started doing, oops, can't do that. We've started using this grouping information in our subsequent analyses so that when we test a potential early marker for autism, we're going to compare 4 different groups, and those are summarized here. We've got our ASD group in blue and our other concerns group, and then 2 typically developing groups. And it's an open question whether high-risk typically developing will be different from low-risk typically developing. So what I've charted here for you is something that we would expect to see. We know that language is impaired in ASD, so I've charted language scores from the Mullen scales divided between expressive and receptive for the 4 groups across 5 time points. And what we're able to do is just to compare where is the ASD group different from the concerns group, because we want to, in making a prediction of diagnosis, we want to differentiate the kids who are on the spectrum from high-risk kids who have other, non-autistic, again, I keep using the expression, but subclinical impairments. And also we'll compare both of those groups to the typically developing kids. So you can tell from the legend that there is a green line and a purple line. Again, my screen purple. But you see that the typically developing groups, high risk and low risk, track each other perfectly. They're just, at least on language measures, they're really indistinguishable. Here you can see a little area where they don't overlap, but there is no significant difference. Well, again, language is a pretty easy test case. What we've been looking at this year, and I want to credit Lavella Gomez, our research assistant in our lab, for coming up with this idea. We've been looking at a very different area of impairment in ASD. We've been looking at adaptive behaviors, and I'll start with a definition. These are skills needed to function in one's environment given one's age. The domains that I'm going to focus on here and that we've been particularly interested in are daily living skills, which include grooming, dressing, toileting, and feeding, and social skills, which has to do with maintaining relationships and participating in group activities. There are a couple reasons why this represents a departure from what we've been doing. We've been looking at very discrete behaviors that we can pinpoint and count and analyze, at the most minute level, things that we can see in the lab. These are things that we can't see in the lab. This is data that we collect by means of a questionnaire, an interview with the parents. It's the parents' report on what the child is like in the real world, the world of people, friends, strangers, rules, customs, tools. This gets at, it steps back quite a bit from the discrete behaviors, and it gets at how the child is functioning. So now what I've done is I've applied this grouping approach to adaptive social functioning. What we know about adaptive social functioning in autism is that it's impaired, but generally what studies have found with older children with autism is that socialization skills are always impaired. That's obvious, right? Daily living skills are impaired in half the studies and not impaired in the other half, so we didn't know what we would find there. What's very interesting to me about this slide is that we see two different things in these graphs. We see significant differences in these skills at 12 months. So in statistical terms, we see a different intercept, a different starting point, and we see very different slopes. This is consistent with what we saw in the language slides, that the variability increases over time. So kids start out behind, and it's not just that they aren't catching up, but they're falling further behind over time. Something about autism, this is the way that I'm going to conceptualize it. Autism is interfering with their ability to learn, and the deficits are accumulating over time. So this to me is interesting in and of itself. This could be an endpoint. Adaptive skills are different early on. This is an early warning sign of autism. Looking at it over time strengthens the statistical models and helps us to predict diagnosis. I mean, if we have these measures at 12 and 18 months, that's going to be quite a robust difference between the kids who go on to get a diagnosis and the kids who don't. But it's not quite enough just to describe what's going on. We want to know why. We want to know what going back to an earlier slide, what are the processes that are interfering with the acquisition of these skills? You will note that these growth curves look a lot like the language curve. So something that is fundamental to autism is interfering with the development of both categories of skills, which they certainly have something in common, but they're not the same measures at all. So what we've been looking at is social constructs. The literature, now there is a literature on early warning signs of autism, and one of the consistent findings is that a variety of different social constructs are impaired early on. Social motivation seems to be impaired, social attention, social interest, social engagement. So we have this nice measure that Marion Sigmund has been talking about for 25 years, I would say. 25 years ago, Marion Sigmund identified the joint attention deficit in autism in her lab with Connie Kazari and Peter Mundy. Joint attention is referencing or directing, and when a child initiates joint attention anyway, they are referencing or directing another person's attention to an object or an event of interest, and they can do this by means of pointing to something, showing something to share an interest, giving it or coordinated looking between the social partner and the object or event of interest. Responding to joint attention is understanding another person's attention-directing behavior. So another person's point, understanding that this means don't look at my finger, but look at the screen. Or to a change in gaze direction. So I look over there, and you might follow my gaze. You might prefer to look at me. Here's what we know about joint attention and autism. As I said, it's impaired in children with autism. Not exactly the same way, not necessarily across the board. Some children with autism do point and show, but overall, it's impaired in children with autism. The development of joint attention skills, it's also impaired in infants who are later diagnosed with autism. That's, the middle paper is out of our lab. But it's been replicated, which is nice. These are different infant sibling studies that have all found joint attention deficits in infants who are later diagnosed with autism. Joint attention is associated with language gain. So variability in joint attention skills early in life correspond with a comparable variability in language development, in the rate at which language is acquired, and also in language outcomes. Now, referring to Dr. Kazari again, her work has shown, her treatment work shows that joint attention can be improved in treatment and that improvements in joint attention correspond with subsequent gains in language. And one of the things that I'd like to emphasize here is that in this treatment study, it was actually the precursor to this study, I guess. No, I'll refer to this study. The joint attention had improved by the time that children left treatment, but the improvement in language occurred down the line. Is that accurate? That's important, and I just want you to focus on that because it's going to come up soon. This is my version of foreshadowing. It's extremely subtle, I know. So I'm just going to kind of cut to the chase. I've been working with an amazing statistician in the Semel Institute Statistical Consulting Group, and we've been modeling growth in adaptive functioning, adaptive behaviors. And what we found was that initiating joint attention at 12 months was significantly related to, these are socialization skills, which again are impaired across the board in children with autism. The 12-month initiating joint attention measure was related to 18, 24, and 36-month socialization skills, not to daily living skills. So they're no stars, not related. The numbers that you're seeing are beta weights, which are roughly the same as correlation coefficients. So I guess the thing that I want to focus on there is this is an indication, IJA 12 at 12 months is an indication of social interest, the extent to which the child wants to share his interest in an event or an object with somebody else. So it's getting at interest and motivation and engagement. Now, RJA was related, sort of close in time. RJA at 12 months, that's response to joint attention following the examiner's points to posters on the wall of the testing room. RJA 12 was related to socialization skills, but check out this line. This is where the action is. Change in RJA between 12 and 18 months was very strongly related to socialization skills and daily living skills. One of the things that I want to point out is that I can't say the impact because these are correlations, but the association, the relationship between change in response to social information, it's increasing over time. I mean, that's a pretty whopping relationship there. We have not, what's interesting about this, what I think makes it a nice complement to Dr. Kasri's work, is that these kids aren't getting treatment prior to 18 months. We collect a lot of data on that. A lot of kids start treatment at 18 months, but something naturalistically is happening. The development of joint attention skills, the change in skills matters for the development of subsequent skills. Our colleague Peter Mundy at UC Davis does a lot of work on joint attention in infancy, and he's described it as a psychological process that potentiates learning down the line. So it's as if, and this is the connection with Dr. Kasri's work, it's as if they're being given a tool with which to go out and do more learning. And this is a nice what do you say, a companion piece to the treatment work that naturalistically kids who are gaining more are achieving, who are gaining more in this particular window, first half of the second year, they're functioning better in the real world later. And a very important point is that this is not limited to the kids who have poor skills at the beginning and the same or worse skills later. This applied across the board. So this applies to kids who look okay at 12 months. It's the change from 12 to 18 months that seems to matter. The next thing that we did is we related these data, the change data, to diagnostic outcome. And I started with asking the computer to just categorize. If knowing these data, which group would you put them in? If I just had risk group in the model, there was a 12.3% error rate. The error rate is slightly more than, well, less than halved. When I add in RJA at 18 months, so this shows that these two lines show that adding the change tells you more than you would know if you just tested RJA at the end of this time window. So change really mattered. I'm done. And it's also, the change in RJA was also related to symptom severity. So this is something I talked about before, wanting to know where somebody falls on the spectrum. Change in RJA predicted the number of autism symptoms that kids had. So this time window is very important. This justifies the work with infants. It also justifies work with kids who don't show impairment at 12 months. It also indicates that testing at multiple time points tells you a lot more than you can learn by looking at a single time point. Still, we don't know a lot about what comes before joint attention at 12 months. It's already a complex behavior, and so our next steps are to try to break it down and to see what's going on in the first year and what the predictors are of individual differences already in 12 months, because most likely that's going to tell us something about who's likely to improve or actually lose joint attention skills during the second year. And so we're waiting to hear about grants, but some of the methodologies that we'd like to apply are eye tracking, which we're already doing to some extent, electrophysiology, which you'll hear about next, we're already doing, and we're getting into neuroimaging, brain scans of infants. Here's some recruitment information for you.
Thank you very much.
You're very welcome. My pleasure.